Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai, and today we are with another legend of bariatric surgery, Professor Muffazal Lakadwala from India. He is a well-known bariatric surgeon, and no doubt he is teacher of teachers, and especially his role in bariatric surgery, education of bariatric surgery, and also I think promotion of bariatric surgery. No doubt we cannot forget this at the globe. And also we can see in any international conference, his role is always in a leading role. Today again we are with him, and it's great honor of me, myself, GLR team, GLR TV, to have such a legendary person. And it's also great honor for me to interview such a prestigious figure. My viewers, as you know, we have finished our 4 interview series, and now we are going on interview series of revisional bariatric surgery. Revisional bariatric surgery is also another reality, and now we are facing, and this is a time to also standardize this, and also we need guidelines. Definitely, there is a lot of discussion already done, and again we need more and more to discuss about revisional surgery. Sir, I will not take your time. Sir, please, over to you.
Assalamu alaikum, Imran, and Ramadan Kareem to everybody. It's great to be here live on this session. I was previously involved in one of the sessions on JLR, and now very, very glad to be part of this revisional bariatric surgery. I've been focusing on, as most people would know, that anybody who's done bariatric surgery for long enough would have the opportunity to increase their volume of revisional bariatric surgery. I was fortunate to have learned a lot of revisional bariatric surgery early on in my practice, because that time, as they say, beggars cannot be choosers. We used to get a lot of revisional work initially from the Western world, from America, from Europe, where insurance was still not completely passed for revisional bariatric surgery. And for cost concerns, patients would come down to India. So a lot of the learning came from that phase. And now we've got our own volume of cases, having been in the field for close to now 20 odd years of bariatric surgery. Some of our own patients operated previously, to some of my own colleagues' patients, to some of the patients from the area and region, all get referred in for revisional bariatric surgery. Imran?
Yes, sir, yeah, so much thanks. Sir, how you define revisional conversion or correction? How you define this one? Is it revisional? Is it correction? Or is it conversion? How you define this?
So basically, revisional bariatric surgery, Imran, is performed to either repair or to change any previous weight loss procedure. All right. Now, the ASMBS guidelines and the recent paper publication that they came out on revisional bariatric surgery meant to actually denotify and to clarify a few of the terms that were related to revisional bariatric surgery, because it was very commonly used: revisional, conversion, correction, or various other terms. So what they defined was that the conversions are used for complications or an inadequate response to the previously done bariatric surgery, whereas corrective procedures were used for primary surgeries that had a poor anatomical construction right in the beginning, or had probably developed a complication, something like a gastric fistula with weight regain, and that's why the patient would need a corrective surgery. A reversal procedure was something wherein the primary surgery had caused an intolerance, such as, for example, a SADI procedure, which had to undergo a malnutrition related. So the only component that you could really convert was the malabsorptive component, or the bypass, whereas the sleeve gastrectomy portion of the SADI could not be converted back. But things like BPD, you could always convert it back to normal anatomy. Things like the Roux-en-Y gastric bypass with neuroglycopenic dumping, for example, you could convert it back into almost like what God has given us, and back to complete conversion of the procedure. Mini gastric bypass with complications, again, can be converted back to absolutely normal. So Roux-en-Y gastric bypass, mini gastric bypass are the two common procedures that can be completely converted back.
Sir, so much thanks. Sir, how you define failure of bariatric surgery? Is this failure of bariatric surgery is correct sentence?
Actually, the terminologies that we used previously for defining failure or success of bariatric surgery, unfortunately, was percentage excess weight loss. Now, we do know that even today, as we want to publish in either SOAD or in obesity surgery, the term percentage excess body weight loss is an arbitrary term. And therefore, it is based more on a notional value of what is your ideal body weight. And that is why most terms that are today being used worldwide are percentage total body weight loss. We do not yet have any kind of criteria that defines success or failure with percentage total body weight loss. Now, the past criteria of percentage excess weight loss said that any weight loss which was less than 50% of the excess weight loss over the 18 or 24-month period, or there was a lack of maintenance of 50% of their excess weight loss, was defined as a failure. Now, we all do understand that these are arbit terms, and some might call success as maybe remission of comorbidities. And for that, you need just merely 5 to 15% of total body weight loss. Some would say that I needed a 10 kgs more of weight loss, and that is why my procedure is failure. So what is defined as failure or success is relative, depending on the patient, depending on the surgeon, and depending on where you are from and what kind of actual outcomes you expect out of your surgery.
Yeah, this is a good point, sir. So what is our expectation? So on the expectation, because our patient also their expectation is losing weight, definite. So if we achieve that target, then it's okay. But when we cannot achieve this, then so we can ask, so this is the failure of our target, our that expectation.
And that is why, Imran, I feel that bariatric surgery is a procedure which is done for a lifelong cure of anything. Now, for example, you take other conditions like a knee replacement. All right, after 15 years, we all do know that a knee replacement will need another replacement. But nobody challenges that. Right now, as bariatric surgeons, we are being really hard on ourselves, wherein we say that if you need a corrective procedure somewhere down the line, it's a failure. I do not think it's a failure because there's so many aspects that are involved. Patient follow-up, what the patient's doing, patient's diet, patient's mental state, patient's lifestyle. And therefore, it's one of the most challenging aspects to define failure or success after bariatric surgery. I think this is a very loose term, and I think many more meetings will need to be done by worldwide experts to actually define in terms of percentage total body weight loss, because most of the medications available today all talk about percentage total body weight loss. They initially, total body weight loss of more than 5% was approved for any kind of medications. Now we do have some of the newer drugs like semaglutide, like tirzepatide, and various other new drugs that are coming in the pipeline, all talking about anywhere close to 15 to 21 to 22% total body weight loss. Right?
Sir, excellent. Sir, it means so still need to public awareness, and especially we must also be aware. So this is not failure, because obesity is multifactorial, and maybe so patient is not cooperative. Patient start to take more soft drinks and also sweet juices. So definite. So and also there is many other factors. So we cannot blame only surgery. This all is maybe you did perfect surgery, but cannot achieve that expectation that we had before surgery.
Yes, Imran. That's why the expectations should not be set too high.
Yeah,
you should
definitely.
say what is the average. Do not promise something which is not possible in bariatric surgery. Do not promise the sky.
Sir, it means so we must talk with the patient before surgery. Patient must be
Yes,
aware.
it's very important. I've seen some of my own colleagues, my fellow surgeons, bariatric surgeons, who go out and say, I've got a cure for diabetes. Now, there is no cure for diabetes. It's a very chronic. It's just like obesity, multifactorial type 2 diabetes. Yes, we've got a very, very powerful tool in bariatric surgery where we can cause long-term remission. But the moment we start using terms like cure and lifelong permanent reduction of your sugars, maybe that's where we'll go wrong. Because when diabetes comes back after a few years, maybe 5 years, 10 years, because patients regain some of the weight, then the patient thinks it's a failure and you had promised too much. So that's why the expectations you set out for the patients should be very realistic. You tell them, yes, this is the most powerful tool that you've got for remission of your diabetes. Even if it does come back, there's a very good chance that you'll have a much better quality of life with lesser chances of micro and macrovascular complications rather than without this procedure.
Excellent. Excellent. So this is important, especially my youngsters, my viewers are youngsters. You must know, no need to promise such a thing. Just so if we can delay, just as Professor asked, so if we can delay these complication of diabetes for 5 years, again, we are winner. So when you will ask, okay, this will be lifelong cure. So again, definitely will ask, so this is a failure of surgery. But when their expectation is like this, so this I will not use this medicine for 5 years. So the side effects, microvascular will delay 5 years. He will be happy. Same in obesity, when we will ask, yes, this is the target. Your sport is also important. Definite. Then if patient cannot lose weight, will not blame to you and will accept. Agree, sir. Sir, next question, because also we have our youngsters. So what is the technical consideration for revisional bariatrics? This is very important. If someone is going to do bariatric surgery, there is a thick tissue, there is adhesion, now facing another anatomy. So please, sir, we like to hear from your side, your experience.
So revisional bariatric surgery is meant usually for people who've had very good experience in bariatric surgery. Please don't go out and do the first case as revisional bariatric surgery, because the anatomy is completely obscured. You do not know where the liver is. You do not know where the G junction is. Sometimes you do not know where the spleen upper pole is. And there are very, very dense adhesions. So please keep another hand in the OR, someone who's experienced, someone who's your colleague, who's your friend, a well-wisher and friend, because the first case might be your toughest case and you land up with a huge complication. We do not want that to happen. And therefore, it is very, very vital that someone with a little bit more gray hair than you is around with you when you're doing your early series of revisional pediatric surgery. Like Dr. Imran said, it's very, very vital to know when to operate and when not to operate in revisional pediatric surgery. Today, endoscopy offers you a vast range of tools where you can avoid revisional bariatric surgery, especially if it's arising out of a complication. For example, if it's an early sleeve leak, you would rather use endoscopy than use a revisional surgery. Especially, there are lots of youngsters who come and tell me they've heard some surgeons say, oh, convert it to a mini gastric bypass from a high pressure zone, it converts to a low pressure zone, and so you'll win it over. Please remember that whatever you do, think 10 times and take 2 or 3 opinions before you contemplate doing any kind of complication revisional bariatric surgery. Because today, endoscopy will win you that time period that you need to go and do a proper corrective or a revisional bariatric surgery rather than jumping in during a complication immediately. The other thing is tissue thickness, like Imran said. I prefer using sharp dissection. So I use cold cut scissors when I need to separate between the liver and the tissue. Because even if I were to cut either in the liver substance or into the stomach substance, I can always take a stitch. Whereas when I use thermal sources of energy, like a harmonic or like a ligature or any kind of bipolar, then it causes charring of the tissue, and it might not appear to damage too much on the table, but later on you will get thermal injury and you will get leaks in the longer term. There are some cases which are very, very, very difficult. For example, gastrobronchial fistulas or gastrocolonic fistulas. Now, here is where your experience comes in. So what I would do is always go in from a virgin area. Do not operate from the war zone, because in a war, when you're fighting, you can get hit by a bullet that comes from anywhere. You do not know. So go to a peaceful area. Go to the area around the right crust rather than the left crust where all the action is happening. Right crust mobilize at least 2 to 5 centimeters of the lower end of the esophagus down and bring it back into the mediastinum, back into the abdomen from the mediastinum, and then look at the area. Do you need to resect? Can you just put a stapler across the puji and that is good enough? Or do you need to cut it? Do you need to then contemplate doing anastomosis in a fresh area? Or do you want to do a gastrojejunostomy? Do you want to do a esophagojejunostomy? Do you want to do any other options? But get into an area of virgin control where there is not too much surgery being done previously. And that's my suggestion. Thickness of the tissue, use the staple, which is a little thicker. So if you're using blue, use green. If you're using green and you find the tissue being too thick, use black. But the other thing, for those with bands, previously placed bands, they always have a pseudo capsule. I always remove the pseudo capsule because that is an ischemic area. If you staple across it, there's no real blood supply and that will cause your leak. So I always remove the pseudo capsule and fire on the virgin area. I think I've tried to cover most of my points, Imran, in terms of technical consideration.
Sir, excellent, excellent. And also it's a great message, especially for our youngsters. So no need hurry up for revisional surgery. And you can't believe that you are thinking this is not that thing that when you will do scope and you will see, just imagine there is left lobe liver adhesion there and you have no space. How you can see there is no like normal anatomy, and as professor also demonstrate excellent and exposure and also the dissection from left crust and also that amazing. Sir, especially, so this question is wide question, definite, and this is not exact answer, but especially for my viewers, for myself, we are interested to hear from your side indication of revisional bariatric surgery. Already I asked, this is a wide question. So definitely we can see this is due to, because main our target is sleeve gastrectomy. That is the most common surgery. Just our target in sleeve gastrectomy. I am not talking other surgeries, just sleeve. What is the indication of revision, definite weight regain and also gain? So we need, sir, here most from your side.
So when we're talking about sleeve gastrectomy, two things to take into consideration. One is the amount of weight loss a person has received at the first instance. Maybe the sleeve did very, very well, and the patient lost at least around 30 to 35% total body weight loss. But then he went on and regained a lot. What was his starting BMI? Was his BMI above 60? Was his BMI above 40? So these are the considerations that you need to take into account. And the second thing is whether the patient has got severe gastroesophageal reflux. So the first thing I would like to do in any patient who comes to me with sleeve, I would recommend the patient for an endoscopy. Endoscopy will tell me whether there is a migration of the sleeve upwards into the mediastinum and whether there is any kind of Barrett's esophagus. If there is Barrett's esophagus, there is no doubt in my mind that you have to consider converting it to probably what is one of the best procedures that we have today for anti-reflux, which is a gastric bypass. It's not perfect, but that's probably the best one that we have today. Now, if there is no reflux and the patient has regained back weight, and I would then do a barium study on that patient or a CT, a volumetric study. Either of these two will give you the volume of the stomach, if there is any abnormal dilatation of a neofundus, or whether there is a large antrum or there is a large sleeve overall. Let's say you've got marginal dilatation of the sleeve overall, and it depends again from which region you are from. I would think that the best procedure today we have for weight regain, substantial weight regain of more than 15 to 30% with a relatively normal sleeves would be conversion to a SADI-S procedure. You can leave a malabsorptive limb of anywhere close to 250 to 350 centimeters, depending on which region you are from. If your patients are the ones who are not people who are going to supplement themselves with proteins and micronutrients and multivitamins and stuff like that, then you would rather do a 350. If you have patients who are going to be very, very good with follow-up and stuff like that, then you do a 300 centimeters. If you're in a Western region with mainly a non-vegetarian diet and you feel that the patient had started off with being a super obese, then maybe consider close to a 250. But I would think a 300 is a sweet spot and you should stick to that. If your patient has got weight regain with gastroesophageal reflux, with what do we say, Barrett's esophagus, the first thing you do is you dissect into the hiatus and you do a cruroplasty. Bring the lower end of the esophagus back into the abdomen and take a couple of sutures. Again, these sutures have to be posterior, not anterior. And do it on top of a bougie, especially when you're learning early on, at least a 38 French bruising. Once you've done this, then you convert to a gastric bypass. Now, remember that you will not get any additional weight loss with a gastric bypass with a common channel, with a biliopancreatic limb of close to a meter, meter and a half. So you'll have to go longer on the biliopancreatic limb. So maybe consider doing more. Look at the total common channel. I always look at the total bowel length when I'm doing revisional surgery, because any total bowel length which is less than 3 to 4 meters, if you're converting to a gastric bypass, you are in trouble. The next you're left with is a mini gastric bypass or an OAGP conversion. Again, if the patient has got Barrett's, I would prefer not converting to an OAGP, but that's my personal preference. Some surgeons might argue that, no, I've got very good results with an OAGP with conversion. So that's your personal belief. They believe that you have a wider anastomosis and there's a faster outflow, so there's no chance of reflux. But I would just believe that with Barrett's there, adding bile on top of that might worsen things in the long term. I do not know of the short-term outcomes. So this is my philosophy. If a patient is older, without too much reflux, I would convert to an OAGP. If a patient has got reflux with Barrett's, I would convert to an Roux-en-Y gastric bypass with cruropexy, but also do a longer biliopancreatic limb, a minimum of around 2 meters. And if a patient is super obese to start with and does not have too much of reflux, I would convert to a SARDS. The only other procedure I didn't speak about is the application of links around the upper end of the esophagus. Now, let's say the patient has lost a lot of weight post a sleeve gastrectomy and not gained back too much weight, but is having just troublesome reflux. So what you can do is mobilize the lower end of the esophagus into the abdomen, do your cruropexy, and do a links procedure. People who've done it, I've personally not done it. People who've done it say that there's good outcomes. It's very early days, only long term. We'll come to know whether this really works. Links as a procedure has been passed by FDA for gastroesophageal reflux disease, not for sleeve gastrectomies. So we'll only come to know when long-term studies come up. Imran?
Sir, yeah, excellent. So also still I have the same question, and also I want to know about when you will prefer surgical intervention, especially weight regain. But I have another question also. So about Barrett esophagus, now your figure is in tetra definite, and you done thousands of cases. You follow how many cases till this time you faced Barrett esophagus?
I think a true picture, Imran, if we were to do endoscopy on almost all our sleeve patients, all right, would be around 3 to 4%.
Oh, 3 to 4% is Barrett
esophagus. In long term, after 5 or 10 years.
There was,
okay. If you were to do scopy on everybody, I mean, there will be a lot of GERD without Barrett's, which would be around 20 to 30%. De novo, which happens in patients with sleeve. But I think Barrett's, because we are not scoping everybody, and therefore we do not know the true picture.
Sir, my question, your experience, your personal experience, how many cases till this time you faced Barrett? Yes, this was Barrett.
Yeah, so I will tell you, I have seen at least 30 patients with Barrett's so far.
This is a big figure. Sir, regarding so when you will prefer surgical intervention, so now we did perfect sleeve gastrectomy. That was perfect sleeve gastrectomy, not, so with your hand, personal you did that standard sleeve gastrectomy, so patient lose 30-35%. You also started that medication and also everything. When you will go for surgery, in this case, patient always in your clinic, oh, doctor, I have not lose weight. Now 3 months, 4 months, now start. Now also I am starting to gain weight and something like this. When you will go, when you will decide in such a case, I am asking only weight regain or not insufficient weight loss. This question is insufficient weight loss. When, and also I will ask about weight regain. My question is only insufficient weight loss. When you will, you will decide to go for surgical intervention in this patient.
So Imran, one is that you've operated on a super obese patient. Yeah, now the terminology has gone. But let's say a patient with a BMI above 60, and you've got weight, but you've still not reached the kind of weight that you want the patient to reach. You've done a first stage procedure, and the patient's lost weight, but that's not the weight he wants to reach as his final goal. Then maybe you should consider around a year and a half to 2 years before the patient starts regaining weight. That is the time, because I would define that also as inadequate weight loss, because your primary goal is to get the patient maybe from, let's say, around 250 kilos to double digits. Yeah. The second thing is, if the patient, for some reason, you've picked the wrong procedure on the wrong patient, right? Maybe the patient has developed a maladaptive eating behavior, is high on sugars, high on sweets, and we do know that sleeve gastrectomy does not punish the patient. It does not cause dumping or anything of that sort, like the Roux-en-Y gastric bypass will cause. So sometimes the patient can get away with maladaptive grazing eating behavior and not lose as much weight as you want them to lose. And that is when you should consider. So if you're looking at another additional weight loss of maybe just another 5% total body weight loss, I would not. But if you're looking at an additional weight loss or another 20% total body weight loss or somewhere around that time, then I would try my medications which are currently available, which I told you, semaglutide, tirzepatide. And if I fail with that also, then I would consider a bariatric surgery. So revisional for any patient now, my patients have to have undergone mental screen. They have to have undergone at least 6 months of nutritional change. And after that only, despite some of the medications, like I spoke, if it's available, some of them are not available. If it's not available, then it's a different thing.
So definitely, I think it will take at least 1.5 years till 2 years. Then you will go for that revisional, we can ask surgery after insufficient weight loss, as I understand. Am I correct?
Not before 18 months at least.
Yeah, this is the good, because especially for our youngsters. So because no need to hurry up again for another surgery, just so that MDT, because this is multifactorial. Obesity is not, the treatment of obesity is not only surgery. The surgery part is, in my opinion, less than 50%. So other factors is also. Sir, we have one question from Ala Wafa, and I can also from, I think, Egypt, because we are also live on Facebook. Maybe his question, because I must repeat his question. His question is about GERD after a sleeve gastrectomy. So we can change to Roux-en-Y, and but he asked about fundoplication remnant. We don't have any remnant after a sleeve.
We don't have remnant. Yeah, we don't have remnant.
We have remnant, so how can we do this? Sir, our question, my next question is about weight regain. So you did standard sleeve gastrectomy. Patient lose weight. We achieved 70 plus percent. So after 3 year, 4 year, again patient start to gain weight. So when you will go, you will consider, you did all MDT, medication, everything. So when you will decide, yes, now patient needs, so patient BMI before surgery was, just imagine, 50, 45. Then he was 26, 27, 2, 3 years he was standard. So now he's starting to gain weight. So when you will go, yes, this is the time for surgical intervention.
One is if from the nadir, he's regained back more than 25% of his total body weight. Yeah. So he's gained back substantial amount of weight. And the second thing that would go in my favor is if his comorbidities start coming back. Let's say his diabetes comes back, or his gout comes back, his sleep apnea comes back, or his NASH is getting much severe, or for example, his proteinuria starts and he gets a lot of proteinuria. So I think all these factors go in. So it's an MDT decision to consider any revision of bariatric surgery. Most of surgeons who've jumped in and done a revisional procedure have regretted it, because there are lots of problems that can happen with revisional bariatric surgery. And I can tell you out of my own personal experience that please don't be trigger happy in considering revisional bariatric surgery. It is not for the faint-hearted. So please take all your chances, explain at every step to the patient that he could probably go back to healthy eating. He could probably take other options. But if he's failed everything else, then at least he's earned his surgery, and the patient remembers that you've at least tried to use all other options rather than considering surgery as the first goal.
Sir, excellent. Sir, regarding this, so NASH, as you mentioned here, so if a worse condition, can we go for any malabsorptive procedure or any, what is your criteria? When, yes, in this stage, we must be careful.
So NASH and NFLD is a very, very complex topic. So until we don't have different scoring systems, there are various scoring systems like the MELD score and various other things. But I would say that if you're considering any kind of surgery, malabsorptive surgery in a patient with NASH or NFLD, please be careful. So most important thing, what you need to understand is, first thing is you must, I operate on cirrhotic patients, the child's A, even early child's B, where there is no evidence of portal vein thrombosis. You can actually operate on these patients. The patients do very well. Sometimes pre-transplant, sometimes when the patient's getting ready for transplant, or even considering during the actual liver transplant, you can consider these surgeries. So there's not too much of a problem with that, but always keep a hepatologist involved so that he can make sure that you don't decompensate because of protein energy malnutrition. Again, the other important factor to consider is mild malabsorption, such as the early biliopancreatic limb lengths of around 1 meter or 50 centimeters, half a meter, won't really affect your liver in the early phase. In fact, they say that a Roux-en-Y gastric bypass does better than the sleeve in some of the studies for NASH. So it's been proven. There's documentary evidence for that. Sir, but don't go and do a SARDS or a BPD, because then you're in trouble.
Yeah. Sir, a patient after standard sleeve gastrectomy, weight regain, you have decided to go for revisional surgery, but patient is smoker. So I give you 3 options: SARDS, one anastomosis, gastric bypass, Roux-en-Y. And if you are choosing one of them, why you are choosing this? Patient is smoker.
So first and foremost, I would really be skeptical on operating on a smoker. But sometimes you can't change people, right? So the only safest anastomosis in a smoker is always going to be your duodenal anastomosis. Any gastric anastomosis is going to predispose you to developing a marginal ulcer. So whether it be Roux-en-Y gastric bypass or whether it be only anastomosis gastric bypass, there's always going to be chance of marginal ulcer. Now, the proponents for the Roux-en-Y gastric bypass will argue there are lesser chances of a marginal ulcer than an OAGB. But trust me, I do endoscopies in all my patients 1 year and 3 years and 5 years post-op. And luckily, in India, it's relatively cheap enough to be able to afford to do endoscopies in these patients in the post-op period. But the marginal ulcer rates is maybe 2 or 3% different from one another, not too different. So you have at least a round of asymptomatic marginal ulcer rate in Roux-en-Y gastric bypass is pretty high. Patient has no symptoms, but they do have marginal ulcers.
So definitely you prefer in such a situation SARDS, that enteroenterostomy is more safer as compared to gastroenterostomy or gastrojejunostomy or gastroileostomy.
Yeah, so there are other proponents as well, right, who talk about the sleeve plus procedures, not the SARDS, not the SASI or the SAGI and various other things, but the jejunostomy kind of the proximal jejunal bypass procedures. CK Wang does a few of those. I don't know the long-term results of that. So I'm not the best guy to comment on that, but maybe you could consider one of those procedures as well.
Is better option. Sir, another question regarding, because we are also facing such a situation, especially in a patient's geared after a sleeve gastrectomy. That is also a challenge, definite a challenge. And literally also you have already mentioned about this. So when we are facing such a situation, that is intractable GERD. So patient is suffering. My question about, so vagotomy, have you any experience? So we can do vagotomy and do Roux-en-Y or do anastomosis gastric bypass?
No personal experience. Vagotomy is a radical concept to consider just because a patient is wanting to smoke despite you doing a procedure. Well, I think it's like feeding the hand that bites it. Vagus is a very, very important structure. And because the patient wants to continue to smoke, just to sacrifice it, I think is something that would not appeal to me. So I would convince the patient to stop smoking per se. I personally have no experience, but I'll leave it up to you, Imran, whether you've got any experience with vagotomy and what are the marginal answer rates for that.
Because we were discussing about this in a also panel, expert panel about this in a smokers, especially weight regain. So we can go for anastomosis, gastric bypass with vagotomy. This was a discussion and hard discussion and definite. Still, this is a controversial topic. We cannot ask, so this is the good or not. But my question about when we will do this Roux-en-Y gastric bypass. So what do you think? Still we save vagus nerve? Some branches are saved?
So I'll tell you something, Imran. For those proponents or those people who are saying, let's do a vagotomy and only anastomosis gastric bypass for smokers. Now, we must remember that the mini gastric bypass or the OAGB ulcer is different from the marginal ulcer of Roux-en-Y gastric bypass because there's a mixed refluxate there. It's not only acid, there's bile as well that is bathing that area. So if you're thinking it's only my acid which is causing me that marginal ulcer, maybe you might be wrong. And that's why if you completely knock off that acid, then you're allowing that bile to play freedom to play and do whatever it wants with your stomach. So be careful with that kind of a concept in only anastomosis. If it's a Roux-en-Y, it's different because there's not going to be any bile in that as a causative factor for the marginal ulcer. So that's my only caveat to those people who think that by doing a vagotomy, maybe you've achieved success. Maybe years down, you might actually land up with a bigger problem.
Sorry, because my personal, as you know, so practice is anastomosis gastric bypass. And because I am follower of Professor Karbahu and his theories and also buffering effect of bile, that we are following that concept that no more than 1 decade. So I am practicing anastomosis. So just my question, personal, I have no data. I can ask personal, I have no data. But so according to different data, also French data, many data, they did biopsies in anastomosis gastric bypass. So these all marginal ulcers were acid based, not bile based. Yes, we have bile gastritis because always bile is there, definite. But ulcer that was in vaginal side, not in stomach side, most of the data is like this. Always perforation is from small bowel, never from gastric side. And most of these ulcers were acid based. Due to this, we prefer PPI in these cases, at least for 6 months after anastomosis gastric bypass, to decrease the acid production. Because in anastomosis gastric bypass, our gastric pouch is bigger, more acid production, and we suppress this. Due to this, I am asking, and this theory, vagotomy, maybe vagotomy, because I can so name, so Professor Helmut Billy, his concept is about this, and he was talking about this, and he's doing this now. So in case a smoker, and also there is a intractable if marginal ulcer, so he preferred to do vagotomy and then anastomosis, and he's going to, I think, share his data.
No, I know Helmut personally, and he's a good friend, and I would really encourage him that Helmut publish this, because that will open up a new area of thinking. You know, we've all noticed that the longer or the bigger the gastric pouch in Roux-en-Y gastric bypass, the higher the chance of marginal ulcer. That's a proven thing. Another thing, Imran, is that your ulcers will always perforate the jejunal side, because the thickness of the jejunal tissue is always more milder than the gastric tissue. Always when the fibrosis happens, the gastric tissue becomes very, very thick, right? So yeah, if you were to see, even in Roux-en-Y gastric bypass, sometimes you see only on the jejunal side. You don't see a marginal ulcer, but you see kind of ulcers on the jejunal side. That's because the acid getting thrown onto the jejunum and it not being able to substantiate. So yeah, I am completely of the theory that yes, vagotomy, what do we use to treat any marginal ulcer, whether it's Roux-en-Y gastric bypass or the single anastomosis gastric bypass, is of course H2 receptor blockers. Yeah, that's the common treatment. Acid does definitely have a role to play, but if we completely knock off acid, will bile cause further damage, which is much worse than just marginal ulcer, is my concern. Not the treatment of the marginal ulcer, Imran. I was alluding to what further damage the bile can cause into your stomach pouch, or if the reflux is much worse, into your food pipe. We have not spent enough years with a large volume of people doing OAGPs, maybe 10, 15, 20 years, because with Roux-en-Y gastric bypass, we've got a history of around 70, 80 years. But with the OAGP, with the sleeve, we all thought sleeve was a procedure without any Achilles heel. Today, we do know that there is a percentage of patients who develop de novo GERD. Certain percentage of people, arguably, you can say 1%, 2%, 3%, depending on who you are. But there is a percentage of people who develop Barrett's esophagus after a sleeve. So that's my concern. So that's only longer term data will tell us where we are headed. I think it's a great procedure, OAGP. So what you're practicing is absolutely correct. I'm just saying that adding a vagotomy to that, just be a little careful.
Sir, another thing that we must also explore here, and also we mention, sleeve is a good surgery, but in good hands. Sleeve is a not simple surgery. Sleeve is a technical surgery. This is my opinion. So if patient selection is very important. So which patient is good candidate for which type of surgery? Unfortunately, our youngsters, because it is apparently easy surgery, just staple. This is not like the same anastomosis gastric bypass. Apparently, it's a simple surgery, but it is not simple surgery. There are many technical points that personally I see in this last 10 years. Personally, so when I compare with 2012 or 13, I have started OAGB. My gastric pouch was shorter. My anastomosis was anterior side. My patients faced more GERD as compared to now in 2023. With the passage of time, when I see many hands, I see my patients, my length of pouch, and this gastrojejunostomy, side to side, posterior, many things when I added, and now I also standardize that I am doing. Not this is my technique, that is a hybrid technique, not MGB original technique, not OAGB original technique. That is the carbo, a mixture of both of them, something like this. But my patients are happy. I am happy when there is no complaint from my patients. Definite, I am happy. Definite, in my opinion, that if we follow standard technique, maybe then we will face, because I personally I see lot of reflux in my patients at initial stage, but now you can't believe, sir, nothing. I am asking, this is zero. I can ask really very, because patient selection very important. I never go OAGB in a patient who is suffering already reflux. I go run by gastric bypass. So patient selection. Initially, all patient OAGB. So definitely, patient already suffering with reflux, you will do OAGB. So patient will face such a situation. Patient selection and that standard technique may be helpful. Are you agree, sir?
Imran, we must understand that the number one procedure worldwide today is the sleeve gastrectomy. So I would not only blame the juniors for going for sleeve gastrectomy. They look at data, they attend international meetings, sleeve gastrectomy is the most spoken about procedure. And sometimes there is a kind of catch 22 situation here, because the people who speak very positively for the sleeve have got some investment stake into the sleeve procedure rising more and more. So sometimes that becomes a big problem. What I would say is that what your philosophy is quite correct. If you have a patient with documented GERD, be sensible. We do know that there is, in the best of hands, with the best of technique, with cruroplasties, with dissection of the hiatus hernia and everything, there's still going to be a percentage higher risk of GERD with the sleeve as compared to any other procedure, be it an OAGB, be it an RYGB, be it any other procedure. So if you have a patient who's got preoperative endoscopy, which I think is a must before you do a sleeve, and patient has some symptoms, is on H2 receptor blockers already, and patient's got documented GERD with grade B, grade C esophagitis according to LA or Hill's classification of around 4 or 3 at least. Be careful when you're doing a sleeve. At least tell the patient there's a very good chance the patient will develop reflux and might need surveillance of endoscopies longer term. If the patient has Barrett's, avoid doing the sleeve is my recommendation.
Sir, so much thanks. Sir, another scenario that is also a real case. Patient with GERD after sleeve gastrectomy. So surgeon did Roux-en-Y gastric bypass. That is a standard, definite. I cannot ask gold standard because this word gold is sensitive again, and many surgeons, okay, standard till now. So Roux-en-Y in the case of GERD after sleeve gastrectomy is standard. But again, patient complaint is GERD. What you will do? No response to medicine, medication. Patient is suffering with GERD. We know standard Roux-en-Y gastric bypass, and there is no reflux. You cannot see. So there was no hernia, no migration. Everything they did standard Roux-en-Y gastric bypass, but still patient is suffering with GERD.
So Imran, like I said, it's a technical thing. So initially, when surgeons want to convert a sleeve to a gastric bypass, it's a simple thing. You just make a small little pouch and you go and join the Roux-en-Y gastric bypass. Now, Roux-en-Y gastric bypass is supposed to be, like I said, arguably one of the best procedures for reflux, but it's not the gold standard. It cannot be. So even after a Roux-en-Y gastric bypass, you're going to have at least 2 to 3% of people who have persistent GERD, right? So the idea is about pulling the esophagus down and doing the cruroplasty. If you've not done that at your first revisional surgery, then probably that's the reason why your patient is still having persistent, because your pouch, your esophagus has moved into the mediastinum, you've not brought it down, and that's where you probably have technically gone wrong. It's a big nightmare if you have a Roux-en-Y gastric bypass and you have still. What I would recommend is do an endoscopy. If there is a migration of the pouch still higher up, you have a great chance. Bring the entire pouch or the lower end of the esophagus down into the abdomen. Do a cruroplasty, and maybe if you have the ligamentum teres, you believe in that, you could do that cruropexy, or you could look at a links procedure there that will prevent migration of the pouch upwards again.
Definitely. Salman, we have many questions on Facebook. So one of the interesting question from Dr. Mijda Ismail, I think from Iraq, he must be. His question is about if patient, so because we did standard sleeve gastrectomy, standard, but that was insufficient weight loss. So are you recommend to go to rule out any genetic issue? Maybe there is also this patient has a genetic issue and also other factors before going to do another surgical intervention.
So most of the genetic cause of obesity usually come as the monogenic cause of obesity. So that means your history taking has to be very robust. Let's say the first 3 to 5 years of life, if a patient has put on a lot of weight, more than expected, it's mainly monogenic obesity. And that's where bariatric surgery will not really work. Post that, there are polygenic cause of obesity. And now today we've identified at least 160 types of genes which are linked to obesity in some form or the other. So yes, you could look at that. But even then, polygenic cause of obesity, even if it's a genetic cause of obesity, if you've done the right robust bariatric procedure, it will work. It might not work as well as in most other patients, but it will still work far better than only monogenic obesity is where bariatric surgery should probably not be done.
Sir, we have another question from Egypt. Their question is after OAGB with severe malnutrition and also you have biliary gastritis. So, what is your experience? Are you prefer to go for Roux-en-Y gastric bypass or completely normal anatomy?
So you have malnutrition. So first thing is measure your total common channel. All right. If your total common channel, like I said, is less than 3 meters, that means that's the reason why you're getting malnutrition. If it is more than 3 meters, let's say you've got a 5 to 6 meter total common channel, then it's about the nutritional supplementation, whether the patient is someone who's taking supplementation or not. If he's someone who's never going to be supplementing himself, then rather than completely converting back to normal anatomy, what I would recommend is convert to a sleeve. At least you'll get some degree of weight loss, which is sustained in this patient, and you will not lose every kind of benefit of the OAGB. So OAGB complete reversals is only in that patient who's completely fed up of any kind of bariatric surgery, and that's when you would consider complete. Bile reflux, it will completely go away when you convert to a sleeve because there is no connection of the bile, and there is always going to be the pylorus there that will prevent bile reflux. So yes, if you are to ask me treatment for malabsorption as well as bile reflux, I would say convert the OAGB into a sleeve gastrectomy. And we do it differently now. So I don't know, maybe I can share my video on JLR with Imran's permission someday of conversion of a sleeve, OAGB to a sleeve, wherein I do a different type of sleeve. I just remove the entire fundus, and it looks like a little different, where the anastomosis is done in an area of preserved gastric blood supply, so you don't have a leak, you don't have any problems, and these patients seem to do equally well. I've done quite a few series. I learned this from Dr. Rana Pullat in the US. He taught me this, and I think I've used that for all my conversions now, from a gastric bypass, whether it's Roux-en-Y or whether it's OAGB, to a sleeve, to a SADI. I use this technique now.
Sir, are you pressing because in such a case when malnutrition after OAGB patient is malnourished, definite albumin is low, and so are you prefer to go first for feeding gastrostomy, feeding tube in that remnant stomach for some time, so in place of TPN or something like this? Have you any experience? Then you can do so when patient feel back, so as they start feeding patient, now condition is better, now we will decide to go for surgical intervention. Or
see, what happens, Imran, is that today with the advent of TPN, we can put in a PICC line, put the patient on TPN, put the patient on albumin for around 4 to 5 days, and most of your nutritional problems are sorted out with aggressive albumin as well as TPN therapy. Yeah, and you go and convert and do a revisional procedure. What happens is, by doing a feeding jejunostomy, you've added one more enterotomy to that procedure. So if you're going to convert again, then you have to think in terms of the feeding jejunostomy. So if you are someone, let's say the patient cannot afford albumin, cannot afford TPN at all, then you should consider doing a feeding jejunostomy.
sir, feeding, not feeding jejunostomy, feeding gastrostomy, because that gastrostomy, that is remnant, just we put
Yeah.
a tube
Yeah,
in.
so that again is a time lag procedure. You're buying time. Why not be aggressive? Because I believe that if you can afford albumin, if you can afford TPN, within 5 days you'll accomplish what that patient will accomplish with a feeding gastrostomy or a jejunostomy over a month or a 2-month period. Imran.
Yeah, sir, thank you. Sir, regarding also this OAGB, because as I know you are not a lover of OAGB, but you are doing, because you are a bariatric surgeon and you are doing all types of bariatric surgeries. Have you faced any this intractable GERD after OAGB and there was no response, and then you did any surgical intervention? Any case in your practice?
So I have converted around 4 patients, Imran, with intractable GERD and severe symptoms of bile gastritis. Okay, proven endoscopically twice or thrice. Luckily, all these 4 procedures were referred into me, not done by me. So, and they were done by surgeons who actually do OAGB or MGB regularly. So I would not fault that technique of doing the procedure, or maybe it was early days of them doing the procedure. If I had gotten my own patients, I would say that I'm not someone who frequently does the OAGB. So probably it was a technical failure of getting that reflux. But all these 4 patients were referred into us because they had gone to the primary surgeon, and he just told them it will settle, it will settle. It didn't settle. And despite repeated therapies of H2 receptor blockers and various other things, when they didn't settle, they came to me. We converted them to the Ruamai. Now they are quite happy, actually.
Sir, we have another question from Facebook. That is regarding weight regain after sleeve gastrectomy, and there is a dilated pouch, and you have decided to go for OAGB. Are you resize that dilated pouch?
You should always do that. With an OAGP, it's not like a SADI. If you were to do a SADI, I would leave it alone because that's a completely malabsorptive procedure. But if you're doing an OAGP, I know Dr. Rutledge might not agree with me on this front, but I would resize the pouch, yeah.
Sir, because we have also viewers are newcomers, I mean not newcomers, so youngsters. This message will be for those youngsters who is eligible for revisional bariatric surgery. And which center? Which center mean not we are going to name any center. Overall, this message will be especially for our youngsters.
So like I said, your center can be absolutely ready to do revisional bariatric surgery as long as you have a multidisciplinary team which has evaluated the patient. You have a very good, robust nutritional follow-up. You have an endocrinology colleague or friend who has already been using semaglutide or tirzepatide or Ribelsis on these patients or some other form of medications. You have a counseling team which has counseled this patient and probably seen that he's not abusing some form of drug. A lot of antipsychotic patients who are on multiple drugs, they tend to regain a lot of the weight. So all these factors have to be taken into account. Then you're absolutely ready to perform the surgery. And if you've done under 100 bariatric procedures, for the first 5 at least procedures, I would recommend call in a colleague who's done enough of revisional bariatric surgery, and then you're ready to go.
Sir, excellent. Sir, regarding endoscopic surgery and role of endoscopic surgery in revisional bariatric surgery, we are interested to hear from your side.
So brilliant question, Imran, because I think endoscopy plays a huge role in any revisional bariatric surgery. In corrective bariatric surgery, when there are complications with a sleeve leak, with a sleeve localized abscess, fistulas, like early sleeve leaks, you have things like stents, you have things like achalasia balloon dilatations for multiple kinks in the sleeve. You have pigtail, you can put double J pigtails, which can really help you drain out all that collection. So all these things are very much there if you were to use it. Again, for weight regain, I would say that the new endostitch devices, which are full thickness devices, or the post 2, which again causes full thickness sleeves, can be used. The GERD-X, they are saying, can be a good effective tool to prevent reflux after sleeve gastrectomy. I don't know whether we've got long-term data on that yet. So we'll have to wait and see. Narrowing of the pouch, ablation with argon plasma of the gastrojejunostomy and of the pouch. They're saying that at 6 months and 1 year, they are getting at least a 5% total body weight loss in excess of what the patient has regained. For dumping, it's one of the best procedures to do a stromal narrowing and argon plasma coagulation. So yes, endoscopy plays a huge role for most of these things and procedures. Then again, for banded gastric bypass or banded sleeves or banded OAGPs, whoever's done it, for complete band erosions, you can just use endoscopy and remove that. You don't need to consider laparoscopic surgery. So yeah, endoscopy plays a huge role.
Sir, so much thanks, because just I was closing, but I have another question, I think also from Egypt. So patient with the Nissen fundoplication, previous Nissen fundoplication, now consulted for bariatric surgery. So what you will do? Are you so prefer to take down the gastric wrap, and so what will be your preference in this case?
So if you're going to do something like a sleeve gastrectomy, then think of the Noka sleeve. When Noka does a kind of a fundoplication kind of wrap around it, it's almost the same thing. Look up the Noka sleeve and you could do the same. If you were to do a gastric bypass again, it's no harm in taking a pouch a little longer and dividing it and leaving your wrap intact, because the fundoplication Nissens was done for GERD. You don't want to disrupt that procedure at all. Yeah, but there are certain surgeons who would say that, no, I don't want the wrap. Then you'll have to completely undo the wrap and go ahead and do your sleeve or something. But there is always going to be an additional chance of GERD after the sleeve. Even after the Roux-en-Y gastric bypass, there's always going to be a chance of GERD. So what I would say is leave the wrap intact, go below that, and either do the pouch gastric bypass with the wrap intact there. It will not cause too much of weight regain in that patient or inadequate weight loss. And think of the Noka sleeve when you're considering a sleeve gastrectomy.
Sir, excellent. So hopefully, Allah Abbas, you Allah Wafa, you will be so also definite with professor. So if you are going to do OAGB also, that is also my personal experience. No need to touch this wrap. Okay, wrap is there. You can make a longer pouch and you can do OAGB. There is no issue, because if you will again touch this and a lot of adhesions, already there is a system, and so definite. Excellent. Sir, your message for our youngsters.
Thank you so much, Imran, for doing this session. I think it's a great learning tool for all you youngsters there. If my only recommendation is only do revisional surgery if it's absolutely indicated, or you will become lesser and lesser of a bariatric surgeon. Trust me, all the white hair I've got from doing revisional bariatric surgery and complications. So bariatric surgery is a lifelong journey. Make sure that you do the best procedure as your first procedure, so that the chance of revision will become less. If at all, whenever you need to do it, you have to do lesser and lesser things. Consider learning more and more of endoscopic surgeries before, or at least get a colleague to do it for you if you're not doing it. Get a multidisciplinary team together if you want to have a career as a pediatric surgeon. And if you have any further questions, please write into Imran and I'll be happy to answer them. And we'll be conducting these revisional surgery workshops all across Asia. So any one of you are keen to be part of it, please write to Imran. He'll get in touch with me. And I'll love to interact with you at any of these revisional meetings. We'll be having it every 3 months across one place in Asia as we go forward. Thank you.
Sir, this is a great opportunity also for me, because we are also facilitating our youngsters for a fellowship program. Sir, it will be great honor if you accept our fellows, because we have a fellow from all over the world. So personally, again, I will schedule a meeting with Amir Khan, and because Amir Khan is our educational director, so it will be honor, sir, if you accept our youngsters, especially. It will be great opportunity also for GLR team and also for our youngsters.
No, please, Imran. It will be a pleasure and honor. And please give my regards to Professor Amir Khan as well.
So my thanks, sir, and also my viewers. So much thanks, and also especially thanks for Professor Muffazal, who is always sportive, encouraging. And we will continue our this interview series of revisional bariatric surgery. And next week, Tuesday, 10 p.m. Dubai time, we will be with another legendary bariatric surgeon. Sir, again, so much thanks, and definite in future also we need your support.
Thank you, Imran, and wish everybody a happy Ramadan and happy fasting for whatever days that are left, and see you soon.
Thank
Inshallah.
you. Thank you, sir.
Bye-bye.
So,
Thank you.
Bye-bye. Thank you, sir.